Hello dear students, myself Dr. Maddineni Srinivas, welcome to my YouTube channel. So in this video we are going to look at the important dermatology image based questions in FMGE exam point of view. So let us begin the discussion with the diascopy, which is the simple OPD procedure of application of the pressure with the glass lid on the skin, and this whitish response it is seen in the patients who are having the erythema of the skin because of the dilatation of the blood vessels, and this can be separated from the RBC extravasation, because of which the reddish discoloration of the skin can be seen, but that will not show any blanching. So the next finding you are able to see is lupus vulgaris patients showing this apple jelly nodules, which is golden brown discoloration of the skin on application of the pressure with the glass line. Next we have some lines which are, one is Blaschko's lines. First one is a Blaschko's lines. So what are these Blaschko's lines? Basically these are the keratinocyte or epidermal cell migration pathways which are going to be seen during the embryogenesis. Remember, these are not going to correspond to arteries, veins, nerves or lymphatics, and you can identify them with the characteristic spiral pattern which is seen over the scalp, and these lines do not cross the midline, and these are imaginary lines which can be seen in certain diseases of the skin, like for example in incontinential pigmentation. So next lines which you are able to see on the right hand side, these are the Langer's lines, which are also referred to as relaxed skin tension lines, and these correspond to the collagen fiber orientation which is present in the dermis. And what is the clinical significance of these lines? Remember, whenever you have to give incision, always try to give incision parallel to these Langer's lines. Next, we have the vesicular bullous disorders. Remember, two important types of the blisters, flaccid and tense blisters. If the examiner gives you flaccid, the examiner is trying to tell you that it is intraepidermal blisters, about which you need to think of intraepidermal blisters. Intraepidermal blisters. And what is the important example for this? Pemphigus group of disorder. It is pemphigus group of disorder. And if the examiner gives you the tense bullous lesions, then the examiner is trying to tell you that it is subepidermal blistering disorder. Subepidermal blistering disorder. Important examples of the conditions which you need to remember are bullous pemphigoid and dermatitis herpetiformis. Of course, linear IgA disease and the rest of the others also fall under this category. And coming to the flaccid bullous lesion, so the first one which we are going to discuss is the most common, pemphigus vulgaris. So remember, in this there will be auto antibodies against desmoglein 3 and also desmoglein 1. Because desmoglein 3 is affected, so there is going to be mucosal involvement. Mucosa is going to be involved, and the skin is going to show multiple erosions and ulcerations, which is not going to show any tendency to heal, but it is going to show a tendency to extend and involve almost the entire skin. And in this patient, there is one very important clinical sign which is called as Nichols-Kiss sign. Nichols-Kiss sign. So in this Nichols-Kiss sign, what are we going to do? Apply tangential pressure on the perilesional skin, and what are we going to observe? We are going to observe separation of the epidermis from the underlying dermis. And the underlying reason for the Nichols-Kiss sign to be positive is, remember, very important, it is acantholysis, which is a separation of the keratinocytes from one another, which is due to the damage of the desmosomes in the case of the pemphigus vulgaris. Okay, next is the biopsy finding, which is very important. On biopsy, skin biopsy, the pemphigus vulgaris patients are going to show one very interesting finding, which is row of tombstone appearance. This is because the stratum basal cells, they are still attached to the underlying dermoepidermal junction with the help of the hemidesmosomes. Remember, desmosomes have antibodies, but hemidesmosomes are absolutely normal. So this is row of tombstone appearance which is seen in the pemphigus vulgaris, and this is another picture which is depicting the same row of tombstone appearance. Next, coming to the Zank smear. So remember, in the case of pemphigus vulgaris, the Zank smear is going to show you. I hope all of you do remember this by this time. So the acantholytic cell. So this is the acantholytic cell, which is a round keratinocyte acantholytic cell. Next, on the investigation of the choice, direct immunofluorescence, we are going to see the deposition of the IgG and C3 in the epidermis intercellularly, giving rise to this characteristic fish net, or it is also called as chicken wire pattern, or it is also called as chicken wire pattern. Remember, direct immunofluorescence is the investigation of choice in the vesicular disorders. Next, we are going to look at the another flaccid blistering disorder, which is the pemphigus foliaceus. And remember, here the antibodies are going to be produced only against the desmoglein 1. So here the patients are going to have only skin lesions, but mucosa will be completely normal. Mucosal involvement will be absent. In this patient, there is going to be mainly scaling over the body, and this scaling is going to be present over the seborrheic areas. So the next condition is dermatitis herpetiformis. Remember, this is a chronically relapsing itchy condition where the patients are going to have the itchy lesions, which are papulovesicles, which mainly involving the extensors. And if you do a biopsy, on biopsy, we can see one interesting finding of the neutrophils, which are collected in the dermal papilla. So neutrophils are collected in the dermal papilla. So these are called as dermal papillary tip microabscesses. Okay, dermal papilla. And if we perform a direct immunofluorescence, we are going to see the deposition of the IgA along the basement membrane zone and also in the dermal papilla in a granular fashion, okay. Next condition is bullous pemphigoid, and remember, in this patients are going to have this tense bullous lesions which are present over the urticarial wheels. And if we perform the direct immunofluorescence, what is the observation which we can see? It is going to be the presence of the deposition of the IgG and the C3 in a linear fashion along the basement membrane zone or the dermoepidermal junction. Very important observation which we need to remember in the bullous pemphigoid. So next we have this hair disorders which are grouped under the non-scarring alopecia, non-cicatricial alopecia. First one which you need to remember is the androgenetic alopecia, which is of two patterns. So first one is a male pattern and the second one is a female pattern. So you can see here the frontal hairline recession is there, and if there is bilateral frontotemporal hairline recession is there, then this is male pattern of androgenetic alopecia. And female pattern, the frontal hairline is going to be maintained and there is only going to be a central loss of the hair. And what is the treatment in these patients? The treatment is also important. Remember, in the case of the females, we can use the 2% minoxidil, and in the case of the males, we can use 5% minoxidil. This is the topical medication, and in the oral medications, remember, we have finasteride, which can be used, which is going to basically inhibit the conversion of the testosterone into dihydrotestosterone. Next, we have this alopecia areata. So remember, alopecia areata is going to present as the complete loss of the patches of the hair loss over the scalp. And this is autoimmune disorder which is going to target the anagen hair bulb and particularly the hair follicles which are consisting of the melanin pigment. And remember, these lymphocytes are present near the hair bulb, giving rise to this swarm of bees appearance. And at the periphery of this alopecia areata lesion, we can see certain interesting hair follicles which have this exclamatory mark hair like appearance, where there is going to be a very thick distal end of the hair and a very thin proximal end of the hair, giving rise to this exclamatory mark hair sign. And remember, the treatment is with intralesional steroids, mainly the triamcinolone. Next, coming to the tinea capitis. Tinea capitis is the tinea dermatophytic infection which is affecting the scalp, And remember, in the non-scarring variety, we have two types. First one is gray patch variety of the tinea capitis, which is due to the Microsporum canis, and the next one is the black dot type of tinea capitis, which is due to trichophyton torsions and trichophyton violation. Okay. Next, we have the secondary syphilis, which is going to produce this moth-eaten alopecia, Very interesting. Secondary syphilis, Treponema pallidum, moth-eaten alopecia. Next, we have the head, necks, and appendages. So in this first one, which you need to remember is the ectopic sebaceous glands. So sebaceous gland usually open along with the hair follicle, just like the apocrine glands. But if the sebaceous glands open directly onto the lips, we call these as Forde spots. We call them as Forde spots. And over the prepuce they are called as Tyson's glands, and over the areola they are called as Montgomery tubercles. Montgomery tubercles. So next is the disorders of the sweat glands, and in the eccrine gland, just remember the miliaria as the name given for the obstruction of the eccrine sweat ducts. And coming to the apocrine glands, remember hydrogenated separator, the patients are going to present in the apocrine gland rich areas, that is axilla, areola and groin, with nodules, sinuses, ulceration, scarring and fibrotic changes. Next one is a Fox-Ford disease, which is also called as apocrine miliaria, where we are going to specifically see the apocrine duct obstruction, which is leading to the clinical picture of the itchy skin colored papules present in the axilla and also in the groin. Next condition is very important, which is acne vulgaris. Remember, the causative organism is Propionibacterium acnes, and it is a pilosebaceous unit disorder. It is a pilosebaceous unit disorder where the characteristic lesions are comedones, and we have 4 grades: grade 1, 2, 3 and 4. The treatment of each grade is important, so you need to identify which type of lesions are seen in which type of condition. So in the grade 1 we are going to classically see the specific lesions which are the comedones, which could be open or closed comedones. Grade 2 papular lesions, erythematous papular lesions. Grade 3 pustular lesions will be there over the body, and grade 4 nodulocystic lesions will be there. So what is the treatment for the grade 1? Remember, it is topical. It is with topical retinoids, which are going to be adapalene and retinoid. In the grade 2, continue the topical retinoids, but what are we going to add in the grade 2 acne? Remember, we are going to add topical antibiotics. Topical antibiotics will be added. Topical antibiotics will be added. And in the grade 3, pustular lesions are present. Topical retinoids will be given here also, and we are going to add oral antibiotics, minocycline, azithromycin and doxycycline. And the topical antibiotics which we can use in grade 2, these are clindamycin and nadifloxacin. And in the grade 4, we remember we are going to use the oral retinoid, which is isotretinoin, which is also called as 13-cis retinoic acid. It is also called as 13-cis retinoic acid, and it is having certain adverse effects. It can produce the dry lips, which is cheilitis, and it is also a teratogenic medication which can produce embryopathy. So very careful prescription should be given. Next condition is acne rosacea. Remember few important buzzwords related to rosacea. It is a chronic inflammatory dermatosis of the face, which is going to be due to the abnormal vascular reactivity, due to the abnormal vasodilatation. We are going to see the telangiectasias and the flushing of the cheeks. We can also see the presence of the papules and pustules over the face. And in the phimosis type of rosacea, we are going to see the irregular surface and nodular appearance of the skin over the nose, and it is called as potato nose. It is called as potato nose, or it is also called as rhinophyma. It is also called as rhinophyma. In the nail psoriasis is important. What is the most common nail psoriasis finding? It is pitting. So it is the depression which is seen in the nail plate, and this is characteristic was deep irregular coarse type of pitting. And in the case of the alopecia areata, remember nail pits are going to be seen in alopecia areata also, but here the pitting is described as superficial, regular and fine type of pitting. Next finding which we can see in the psoriasis is going to be the presence of this subungual hyperkeratotic material under the nail plate, subungual hyperkeratosis, which is ultimately going to produce the separation of the nail plate from the nail bed, which is onycholysis. And there is a most pathognomonic, most characteristic finding which is called as salmon patch in the psoriasis patient. So salmon patch, or it is also called as oil drop sign. It is also called as oil drop sign. Next is the pigmentary disorders, in which we have the Becker-Snevers, which is characterized by the presence of the hyperpigmented patch, and also there is going to be hypertrichosis, mainly involving only one side. It is seen in the puberty. It is seen during the puberty. Okay, next are the three conditions which are shown below. So these are the dermal melanocytosis, where the melanocyte is getting arrested at the dermis level instead of reaching the stratum basal, and because of which we can see the lumbosacral area becoming blue in color. This is called as Mongolian spot, Mongolian spot. And we have the nevus of Ota, which is going to affect the face, and the sclera also can be blue in color. Next, we have nevus of Ito, where there is going to be bluish discoloration mainly present over the upper back. This is the first picture which is showing you the presence of the hyperpigmented patches over the face, and this is melasma. If this occurs in a pregnant woman, we call it as a cloasma. Next, we have these hyperpigmented macules which are present over the photoprotected areas. These are called as lentigens. And if there are mucosal lentigens, and if there is any GI system abnormality, GI polyps are present, then think of the Peutz-Jeghers syndrome, which is surgery topic. Next, this first patient is a albinism patient, which is basically due to the defect of the tyrosinase enzyme. Melanocytes are absolutely normal. So there is going to be involvement of the iris, skin, and also the hair. So all these three structures, if they are affected, oculocutaneous albinism we call it as. Next is pabaldism, where this characteristic lesion which is seen over the forehead, it is called as white forelock, and this is the buzzword which you need to remember related to the pabaldism. So this is another patient where you are able to see the white forelock, and also you are able to see the depigmented lesions over the body. Next is vitiligo. Vitiligo is due to the damage, autoimmune damage of the melanocytes, because of which we are going to see the depigmented lesions over the body. And in this patient, we can also see the presence of the white colored hair, which is called as leukotrichia, and there is the observation of the similar looking lesions developing along the lines of the trauma. These are called as Koebner's phenomenon. This is called as Koebner's phenomenon. Koebner's phenomenon can also be seen in other conditions also. Remember, we can have the small mnemonic PSLV, Polar Satellite Launching Vehicle, according to ISRO, but according to dermatology, it is psoriasis, lichen planus, and vitiligo. In all of them, we can see this Koebner's phenomenon being positive. In all of them, we can see this Koebner's phenomenon being positive. So this is the image which is showing you a special type of vitiligo, which is following a dermatome, which is unilateral, and this is called as segmental vitiligo. Segmental vitiligo, remember, these are the patients who are going to have the vitiligo which is going to become stable after 1 or 2 years of time. Next is chemical leukoderma, where the rubber is going to produce the damage. The rubber consisting of the molecule which is called as MBEH, monobenzyl ether of hydroquinone, will damage the melanocytes, producing this whitish discoloration along the areas wherever there is contact of rubber with the skin. Similarly, bindi is going to consist of PTBP, which is para-tertiary butylphenol, which is again going to produce damage of the melanocytes. Next is the papulosquamous disorders, in which you can remember the first one is psoriasis, where we are going to see erythematous scaly plaques present mainly over the extensor surfaces, the knees, the elbows, and the lumbosacral areas. And if there is a joint involvement, it is classically and if there is a joint involvement, it is mainly going to affect which structures? It is going to affect the distal interphalangeal joints. And you can also see the presence of the oil drops in this nail. And what is the treatment of the psoriatic arthritis? It is going to be with methotrexate. It is going to be with methotrexate. So there are other types of psoriasis which you need to remember. So pustular psoriasis, where there will be pustular lesions all over the body, and then another one is erythrodermic psoriasis, where the patients are going to have where the patients are going to erythrodermic, okay, dermic. So erythematous skin along with the scaling which will be present, involving more than 90% of the body surface area, can be seen. And this is the Auspitz sign, where we are going to take a glass slide and we are going to scrape the scales. We are going to see the final pinpoint bleeding spots. Pinpoint bleeding spots can be noted as an end point, and this is characteristic of the psoriasis vulgaris. Next, in the biopsy of the psoriasis, remember important points are there. So in the stratum corneum, the thickening is called as hyperkeratosis, and persistence of this nucleus in the stratum corneum, it is called as parakeratosis, and presence of the neutrophil collection in the stratum corneum, it is called as Munro's microabscess. Stratum granulosum, remember, it is going to be less thick or it can be even absent. In the stratum spinosum, remember, there is going to be again a collection of the neutrophils, and these neutrophilic collection we are going to call it as spongiform pustules of Kogoch. Spongiform pustules of Kogoch, there is going to be elongated reteriges present, and also there can be dilated dermal blood vessels. Dermal blood vessels can show dilatation. So next is this picture, very important, where you are able to see raindrop like erythematous papules which are present over the trunk in a child who had previous history of the sore throat, and this you have to think of as a special type of psoriasis which is called as gutted psoriasis. What is the treatment of this patient? Because it is associated with group A beta hemolytic streptococcus, the treatment is going to be with the macrolide antibiotics. So next is this table which is showing you the drugs of choices. Methotrexate is a drug of choice for psoriasis vulgaris and also for psoriatic arthritis. Acitretin, which is oral retinoid, is the drug of choice in the case of the pustular psoriasis, and steroids are usually contraindicated in the patients of psoriasis, but in the two special types of the psoriasis, which is impetigo herpetiformis, which is the pustular psoriasis which occurs in the pregnancy, and psoriatic erythroderma in the pregnant woman, we have to use the corticosteroids instead of any other medication, because others, methotrexate and also acitretin, both are teratogenic. So next condition is the lichen planus, in which the patients are going to have the skin lesions over the flexor aspect. The skin lesions are described as plain topped purple papules or plaques which are associated with pruritus, and these lesions are plain topped. Okay, so this is a description, and on the mucosa we can also see this whitish lacy network like pattern which is called as, very important, Wickham stripe, and this can also be seen in the mucosa as you are able to see here. And very important nail finding, which is the proximal nail fold causing damage to the nail plate and attaching itself onto the nail bed, it is called as pterygium. It is called as pterygium. So in the histopath of lichen planus, remember, in the stratum corneum there is going to be thickening of the stratum corneum, and in the stratum spinosum, remember, we are going to identify the reteriges, which are called as, which are described as sawtooth reteriges, and these sawtoothing is because of the damage which the lymphocytes which are present in the dermoepidermal junction are going to produce. The damage due to the band like lymphocytic infiltration at the dermoepidermal junction is going to produce this sawtoothing of the reteriges. Okay, we can also see the presence of the Max-Joseph space due to the damage of the stratum basal layer, and also we can see the civate bodies, which are the colloid bodies or the apoptotic keratinocytes which are present in the epidermis. Coming to the Pityriasis rosacea, remember, Pityriasis, scaling, rosacea, erythematous lesions. So in the causes you can remember it is HHV7 which is associated with Pityriasis rosacea, and in the lesions, remember, over the skin, the initial lesion which can be seen is the Herald patch. It is Herald patch. It is also called as a mother patch, which is going to have a characteristic scale which is called as collarate of scale, and we are going to ultimately see the development of similar looking daughter lesions over the back, which are associated with the appearance, which is Christmas tree appearance. Coming to the bacterial infection, so remember, non-bullous impetigo, it is also called as impetigo contagiosa, and here we are going to see this honey colored crust, very important. And in the bullous impetigo, remember, we are going to have the causative organism which is only and only staphylococcus, only causative agent is staphylococcus, and the toxin, exfoliated toxin A and B are going to produce this bullous lesions. And in the children, if these toxins are going to spread hematogenously, and it is going to lead to the staphylococcal scarlet skin syndrome, which is also called as Ritter's disease, where the children are going to have this erythematous skin bullous lesions, and ultimately there will be sheet-like epidermal peeling. But because this is due to the damage of the desmoglein 1, desmoglein is absolutely normal, so mucosa is going to be completely spared in the children who are having staphylococcal scarlet skin syndrome. One more important point related to impetigo contagiosa is because staphylococcus and also streptococcus both can be associated. So Post-streptococcal glomerulonephritis can be one very important complication of the impetigo-contagiosa. Next, you have erysipelas, which is also called as Saint Anthony's fire. Remember, this is due to the streptococcus, and you can see the patient's skin which is going to be infected, and the skin is going to become erythematous. Inflammation will be seen with well-defined margins, whereas in cellulitis it is infection due to staphylococcus or streptococcus, and here the involvement is very deep, so we can see very ill-defined margins present in the patients of cellulitis. Next is paronychia. Remember, paronychia is the infection of the nail folds, and there is going to be pus and erythema in this patient. So acute paronychia treatment is going to be with antibiotics. Cutaneous Corynebacterial infection. So remember, erythrasma because of the Corynebacterium minutissimum. The patients are going to have asymptomatic red or blackish hyperpigmented patches in the axilla and also in the groin. And on wood slump examination, we are going to see the coral red fluorescence. Very characteristic coral red fluorescence can be seen in the patients of the erythrasma. So next we are going to see the fungal infections. So Pityriasis versicolor, which is going to be produced due to the Malassezia globosa and furfur, is going to manifest as both hypopigmented macules and patches and also hyperpigmented macules and patches. That is the reason why it is called as versicolor, versatility in the color. And we are going to see the lesions are going to have the brany or furfuraceous scaling over the surface. Okay, and on the KOH mount, we are going to have the very interesting finding which is called as spaghetti meatball appearance because of the combination of the spores and also the fungal hyphae. And on wood slump examination, the fluorescence which we are going to see is called as yellow fluorescence. And next condition is the tinea capitis. The inflammatory types of tinea capitis are which are going to produce scarring or cicatricial alopecia. Scirion, which is because of the trichophyton verrucosum and trichophyton mentographides. We are going to clinically see the boggy swelling, easily pluckable hair present in children. Whereas in the next condition is the favors, where we are going to see the causative agent as trichophyton shortlaney, and we can see cup-shaped scutula, cup-shaped yellow-colored scutula over the scalp. Both these conditions are associated with scarring alopecia, so the permanent hair loss will be seen. Next, subcutaneous mycosis. Remember, these are also called as implantation mycosis. We have three conditions. The first one, sporotrichosis. Second one, chromoblastomycosis. Mycetoma, third one. So in the sporotrichosis, remember, causative organism is Sporothrix shinki, and it is a rose gardener's disease where the patients are going to have the lesions in a linear fashion along the lymphatics, and this is going to be called as sporotrichoid pattern of the lesions. Next is the chromoblastomycosis, which is also called as verrucous dermatitis because the lesions here are going to be verrucous. And on 10% KOH or biopsy, we can see the characteristic bodies which are called as copper penny bodies, medullary bodies, muriform bodies, or sclerotic bodies. Next, mycetoma. Here the patients are going to present with three important findings, which is triad of the granules or grains and sinus tracts and also tumefaction. Tumefaction is nothing but swelling. So these three changes, if they are present, think of mycetoma, and mycetoma is of two types, eumycetoma and actinomycetoma. In the case of the eumycetoma, the granules are going to be dark in color, whereas in the case of the actinomycetoma, the granules are going to be pale or yellow in color. Okay. Next is viral infection. So if there is a grouped vesicles present near the lips, we call it as orolabral herpes, or it is also called as fever blisters or cold sores. And varicella zoster virus, the primary infection is going to produce a varicella or chicken pox, and the reactivation is going to produce what is called as herpes zoster or shingles, which is going to manifest in the form of the grouped vesicles along a dermatome unilaterally over a erythematous base. Next is a molluscum contagiosum, which is a pox virus, a molluscum contagiosum virus, which is going to produce this characteristic umbilicated pearly white papules, which are going to follow a linear pattern in few areas because the trauma is going to auto-inoculate the viruses, producing the pseudocombinance phenomenon. Next is the hand, foot, mouth disease, which is due to the enteroviruses, which is enterovirus 71, and Coxsackie virus A6 and A16, where there will be papulovesicular lesions present over the hand, foot, and also in the mouth. So in the STDs, remember, the anogenital warts are also called as condylom acuminata, which are going to present with a verrucous or rough surface lesion involved in the male and female genitalia. Okay, and this is a normal physiological picture which is showing you the pearly penile papules which are present over the coronal sulcus. coronal sulcus. Next is the genital discharge diseases. So we have vaginal discharge and also urethritis, urethral discharge. So we are going to focus on the urethral discharge. Gonococcal urethritis due to the Neisseria gonorrhea, and non-gonococcal urethritis, it is due to the chlamydia trachomatis mycoplasma, and also the trichomonas can be associated with non-gonococcal urethritis. And in the Neisseria gonorrhea, remember the severity is going to be the important one, because the patients are going to have frank pus and also constitutional symptoms. The gonococcal urethritis is considered more severe form of the urethritis when compared to non-gonococcal urethritis. And in both these patients, the treatment is going to be with the kit number 1, which is grey colored kit consisting of the cefixime 800 mg. So recently changes were made in this NACO kit, so I will try to make a video on this also. So in the kit number 1, we are going to have the azithromycin 1 gram stat, and cefixime, instead of the 400 mg, now we are going to have 800 mg stat dose. Coming to the syphilis, due to the Treponema pallidum, and in the primary syphilis, we are going to have a syphilitic ulcer which is called as hard chancre, and the characteristic feature is going to be, it is single ulcer which is a very very painful, a tender ulcer, and it is associated with no bleeding on touch, and it is clean based ulcer. So in the secondary syphilis, remember, if this condition is not treated properly with the injection benzethin penicillin, then the patients, the treponema it is going to spread through the blood, producing this condyloma lata, very important, condyloma lata, which are the mucosal lesions with broad surface and moist lesions. And also we can see the presence of the hyperpigmented macules and patches over the palms, and so these are called as palmar syphilids. And of course, secondary syphilis, the patients are also going to have the moth-eaten alopecia. We have already seen this. Next condition is chancroid. Remember, the causative agent is Haemophilus ducreyi. The patients are going to have cry very severely. Why? Because both the ulcer as well as the lymphadenopathy are very very painful. And in this condition, we can see this lymphadenopathy, which is specifically characteristic, called as bubo. And if you perform a stain, it is going to show you gram-negative cocobacilli in a school of fish or railroad track pattern. And what is the treatment we are going to use? It is going to be the azithromycin, which is the treatment in the chancroid. Next is genital herpes. So it is herpes simplex virus 2, and we are going to see the grouped vesicles over the genitalia, and these are going to rupture and leave behind the erosions over the genitalia. Lymph nodes, remember, the lymph nodes are enlarged and they are going to be tender. Treatment is going to be with the kit number 5, which is consisting of acyclovir 400 mg TID for a period of 1 week. Next is the donovanosis, which is also called as granuloma inguinal or granuloma venereum, and it is caused due to Calimactobacterium granulomatis, or it is also called as Klebsiella granulomatis, where we are going to see this ulcer over the genitalia described as beefy red painless ulcer. And in the inguinal lymphadenopathy, remember, these patients do not have any inguinal lymphadenopathy, and it is pseudobubo, which can be seen as a subcutaneous swelling in the inguinal lymph node area. And if you perform a crush tissue smear, we are going to see this characteristic cells which are called as Pund cells, and Pund cells are basically the histiocytes, macrophages, inside of which we are going to have this Donovan bodies, which are described as closed safety pin appearance. Lymphogranuloma venereum, remember, the causative organism is Chlamydia trachomatis, and we are going to see characteristic lesion in the inner lymph node area, which is again called as bubo, just like in the chancroid. And here we are going to see a small groove which is called as groove sign of Grenblatt. And what is the treatment which we are going to use in the case of bubos? Remember, kit number 7 is going to be used. So this is kit number 7, which is going to consist of the doxycycline and also the azithromycin. So next we have the allergic contact dermatitis. Remember, the hair dye is going to consist of paraphenylene diamine, and in the jewelry, remember, nickel is going to cause the allergic contact dermatitis. In the bindi, para tertiary butylphenol is going to produce the ACD, cement potassium dichromate. And what is the investigation of choice? It is patch test. So patch test is the investigation of choice for allergic contact dermatitis. Okay. So in the urticaria, remember, we are going to have this dermographism, ability to write over the skin. Because of the mast cell degranulation, histamine will be released, and we are going to see the classical lesions, primary lesions, which are called as wheals over the body. Here you are able to see a child who is having yellow greasy scale present over the scalp. This is called as, remember, it is cradle cap dermatitis. It is called as cradle cap dermatitis. And here you are able to see the cutaneous mastocytosis, which is also called as urticaria pigmentosa. The child is going to present with hyperpigmented macules and patches over the trunk mainly, and below these mast cells are proliferating. So if you stroke these lesions with the blunt end of a pen, then we are going to see the development of the urticarial wheal, and this is what is called as Darier's sign. This is what is called as demonstration of the Darier's sign. Next is a scabies, which is a parasitic infection or infestation, which is due to Sarcoptes scabies var hominis mite, which is associated with the characteristic burrow, which is a pathognomonic lesion, which can be seen present in the stratum corneum. And the involvement is classically seen of the web spaces in the patients of scabies. And what are the treatment modalities we are going to advise? It is topical permethrin, topically permethrin, and orally it is ivermectin. It is ivermectin, which is oral preparation. A special type of the scabies, which is called as crusted scabies, where the patients are going to classically have this hyperkeratotic lesions over the body, and the mites will be millions in numbers, and the itching is very, very minimal in these patients. Coming to the lupus vulgaris, so here the lesions are described as annular lesion, which have a central scarring, and the lupus vulgaris is because of the cutaneous mycobacterium. It is a cutaneous mycobacterium tuberculosis. Central scar will be present. This next condition is called as scrophaloderma, which is due to the underlying lymph node, bones or joint, where the MTB bacilli is going to contagiously spread onto the skin surface, producing the subcutaneous swellings, and also ultimately nodules and ulcerations are going to be produced, and the most common site is going to be cervical lymph node area. Next is a fixed drug eruption because of the drug reaction. The drugs are, you can remember, metronidazole and also NSAIDs. There is going to be development of the dusky red hue, which is surrounded by a proper erythema over the areas. What is the classical point here? Fixed drug is going to produce fixed lesion or the fixed site. So that is the reason it is called as fixed drug eruption. So you can see the lesions are going to leave behind very, very bad pigmentation in the case of FD. Next condition is erythema multiforme. The buzzword in this is, remember, it is target lesion, or it is also called as iris lesion or bullseye lesion, which is classically going to involve the extremities, distal extremities, palms and soles, and this is importantly associated with herpes simplex viral infection. It is importantly associated with the herpes simplex viral infection. Next is SGS and TN. SGS and TN, this is a drug reaction due to the drugs. More than 90% of the times it is associated with drugs, and if the involvement is more than the involvement is less than 10%, if the involvement is less than 10%, we call it as Stevens-Johnson syndrome. If the involvement is more than 30% of the skin, we call it as toxic epidermal necrolysis. And we are going to classically see targetoid lesions where there will be only two zones. So in the target lesion, there will be central erythematous zone followed by a pallor middle zone and peripheral zone of erythema. But here in this patient, we are going to only see two zones. The central edematous pale zone is going to be absent. Patients are going to have very, very bad mucosal involvement. So there will be hemorrhagic crust which can be seen over the lips, and the skin is going to be completely peeled off. This is called a sheet-like epidermal peeling, which is classically seen in the patients of 10. And remember, flagellate dermatitis, it is also associated with flagellate pigmentation. Bleomycin is a medication. Minocycline can produce lesions, bluish discoloration of the acne scars. Next is the genodermatosis, which are also called as phacodermatosis. So remember, neurofibromatosis type 1 is very important for you to remember. Neurofibromas will be present on the skin. This is the axillary freckling, which is also called as Crovicin, and we can also see cafe ole macules, that is hyperpigmented macules over the body, and plexiform neurofibroma, which is the classical pathognomonic finding in the patients of neurofibromatosis. And these are the iris lesion nodules, which are iris hematomas. Tuberous sclerosis complex, remember, it is also called as epiloia. So patients will have epilepsy, low IQ, and A stands for adenoma sebaceous, which is also called as angiofibroma, And the major skin patches, one of them is adenoma sebaceous, rest of the others are the depigmented lance ovate shaped lesions, ash leaf macules, the leathery plaque, which is a shagreen patch, and the covenant tumors or periangual growths, which are called as the covenant tumors or periangual fibromas. Now some one-liners very quickly. So this is the patient of the discoid lupus erythematosus who can show this carpet tax sign. This is a patient having butterfly rash and it is systemic lupus erythematosus. Patient having salt and pepper pigmentation. So this is a patient of systemic sclerosis. Systemic sclerosis. Now you are able to see this image which is showing the velvety texture of the skin in the axilla, and this is called as acanthosis nigricans, which is associated with insulin resistance, obesity, and also diabetes mellitus. And on the right hand side, you are able to see a patient who's having alopecia, acne, deeper voice, hirsutism, menstrual cycle irregularities, clitoral hypertrophy. So all these are also features of the polycystic ovarian syndrome, which is basically the cause associated with the insulin resistance. So this image is very important from your exam point of view. Castle's necklace seen in the pellagra patients due to the niacin deficiency, vitamin B3 deficiency, seen usually in the maize or jowar eaters and also in the alcoholics. What is the treatment? We are going to supplement the vitamin B3. So here you are able to see a child who is having peri-orifacial dermatitis, and also there is alopecia and there is diarrhea in this child. So it is acrodermatitis enteropathic. And so remember, in the pellagra we have a triad of 3Ds: dermatitis, diarrhea and dementia. Okay. So in the Hansen's disease, remember few important points. Tuberculoid leprosy, the patients are going to have annular lesions, and in the BT, borderline tuberculoid leprosy, they are going to be characteristic satellite lesions which are surrounding the main lesion. And the patients are predominantly going to have the absence of the sensations along with these lesions. Coming to the mid borderline leprosy, remember few important buzzwords. The patients are going to have the lesions which are described as inverted saucer shaped lesions, and they are going to have a center which is called as punched out center. The lesions are described as geographic map like lesions, and also because of the punched out appearance, the lesions are also described as Swiss cheese appearance. And in the lepromatous leprosy, remember the patient's face is going to look like a lion, so it is also called as leonine facies. Next is the lepra reaction. So we have two types of lepra reaction. So first type of lepra reaction is type 1 lepra reaction, which is due to the type 4 hypersensitivity reaction, where the previous lesions are going to become inflamed. Whereas in the type 2 lepra reaction, remember it is a type 3 hypersensitivity reaction. So there are going to be new lesions produced, and these are called as erythema nodosum leprosum. And remember, in both of them, the treatment is going to be with continue the multi-drug therapy with rifampicin, dapsone, clofazimine, and just add the steroids. Next is the ABCDE, which can be seen associated with the malignant melanoma. Remember, asymmetry of the lesion is going to be seen, border are going to be irregular, color is going to be very irregular. At few areas there will be very black color, at other areas there will be very pale color. Diameter will be more than 6 millimeters, and evolutionary changes will also be seen in these lesions. Next is basal cell carcinoma, which is a locally invasive tumor and is the most common type of skin tumor, which is going to present initially as pearly white nodule with surface telangiectasis, but ultimately, because it is locally invasive, ulcer will be produced, and this ulcer is called as rodent ulcer, and it is going to have rolled out edges. And what is the site? Classically above the line joining the angle of the mouth and the tragus. That is a classical site. So coming to the next condition, xeroderma pigmentosum, and here you can remember it is a nucleotide excision repair defect, because of which the genetic mutations are going to be piled up, and there is going to be possibility of all the types of malignancies, BCC, SCC, malignant melanoma in these individuals. So this is a flow chart which is going to help you to understand and come to a diagnosis of this sexually transmitted disease. So if the patient is coming with multiple painful genital ulcers, there are two possibilities. One is chancroid and the other one is herpes genitalis. Remember, if the bubo is mentioned, the painful lymphadenopathy bubo is mentioned, then the diagnosis is going to be chancroid. And if the patient is not having any bubo but painful lymphadenopathy is present in the inguinal area, then the diagnosis is going to be herpes genitalis. Now coming to this side, single painless genital ulcer. Observe the lymph nodes. If lymphadenopathy is absent, then what is going to be the diagnosis? It is going to be the donovanosis. And if the ulcer is painless and the lymphadenopathy is also painless, then think the diagnosis is going to be syphilis. And if there is a bubo which is painful, then the diagnosis is going to be lymphogranular venereum. Okay, so this was the session, quick session. So I hope all of you have enjoyed this session. If this session was helpful, please do hit that like button. And if you're new to this channel, please do subscribe to my YouTube channel so that you are going to get such awesome content of dermatology on a regular basis. So all my group links are there in the description. You can check them out and join them. And always remember, never give up on your efforts. We can't call a person as failure until he or she never gives up on their efforts. Remember this. And thank you so much. Happy learning, all the dear students. So if you have any more doubts, you can leave them in the comment section. And I also have done a video on the previous year questions of FMG. I will leave the links for them in the description, comment section, also in the iCard. You can check those and you can also watch that previous year questions of FMG examination. So thank you so much. Do subscribe and also share this among your friends. Also do discuss whatever was taught in this particular video, so that you are going to remember whatever was discussed in this particular video for a longer period of time. So I hope this video was helpful. Thank you so much for watching this video till this point. Happy learning. All the very best for your examination. Sarvam Sri Krishna from Sarve Jana Sukhina Bhavantu. Sarve Jana Sukhina Bhavantu. Bye bye. Thank you so much.